Today I'm going to be talking about liver contrast agents. Again, I'm Manjul, very informal up in here, so just feel free to interrupt or if you have questions or whatever's on your mind. Can we dim the, yeah, exactly. Keep going, keep going. Okay, now we can see it. Okay, perfect. So today we'll be talking mostly about gadolinium, which is this structure. This is not the most exciting topic, so maybe we can warm up a little bit. This is a patient who's getting a full body scan, it looks like at the airport, and they say, could you maybe fax a copy to my radiologist? And this is sort of a clip at how fast moving our field is really forwarding. There was a time when all the results were faxed, right? But now, it's funny, like doing these advanced MRIs and, filling gigabytes worth of storage with these images, and then still we're faxing some of these results by paper to our, to our referring clinicians and whatnot. So we really can't even keep up with ourselves in our own practice. Here's some more interesting images. Anyone know what animal this might be? Fish is a good guess. I kind of thought that when I saw this too. Frog? Not a frog, no. It's a type of dog. Pekingese is a good guess. This is a pug with these humongous eyes, so cute. And then this is me most days. I feel like I have a pretty big brain, but a small amount of it's functioning, and it's like inside the bigger brain and constantly kind of trying to find new material and stay energized. So this topic is sort of like that, liver or contrast agents in general. It's something we use all the time. I'm going to try to weave some of the physics that I know we all love into this talk, so it's a refresher that makes sense and sticks with you all. The bottom line is contrast agents are one of the few medications we administer as radiologists for most of us in our practice. So it is important to know how to use them, how they work, which contrast agent to select and why. It's not really good enough to just say, oh, we did that study with contrast and not quite understand why or how or when and why we use them. So I will tell you also that now in the day and age of the internet and patients being more and more cautious, I can't tell you the number of times a patient has asked me and said, I don't want to get the contrast agent, I don't want the radiation. Or, I don't want the contrast agent, I've heard it's dangerous or it affects my brain, or, I might leave a little bit of it. So it's good to just be aware and be very knowledgeable about this very important medication that we're administering. So, contrast is relatively recent, right? In 1982, at RSNA actually was the first presentation ever of contrast, not that long ago. Some of you were born after, a lot of you were born after 1982. I was not. So it does feel really fresh to me, even thinking about this being a newer agent than me. So in 1982 that happened. In 1984, Schering, now Baer, presented the first paper as gadolinium being used as a contrast agent in imaging. In 1988, DTPA, or Magnavist, was approved as the very first contrast agent. And between 1988 and 1999, this decade, this period, 30 metric tons of gadolinium was used for imaging since 1988. So in that decade, 30 million tons. Okay, now, in 2022, 50 million tons of gadolinium are being used every single year. So 1 year of our current use exceeded that of 10 years of prior use of gadolinium. So our understanding, our basic framework of this agent is new and fresh and recent. I think a lot of us kind of conceive MRI as old or, having been around forever, but it really is a new technology in the grand scheme of things. So it's important to remember that. So basically, what is the use of gadolinium? Who cares and why? So contrast agents in general, what we're hoping for them is paramagnetism. So what we're looking for in all forms of MRI, and I'm going to give you my idea of a review of MRI, which is 3 slides. Kind of the basics, how it works, but the idea there is basically that in our bodies, when you put a patient in an MRI, there's a big magnet, right? What we call the B naught or B sub-zero. That's 1.5 or 3T or whatever. Your body is full of protons from water, right? And those protons are electromagnetic. Not as much as an electron, but still they do carry some magnetism. The idea of MRI is to discern differences between those materials, even though they're all very similar, right? Fat, water, soft tissue are all within milliseconds of each other in terms of their precession. And what that means is MRI is looking to exploit these tiny differences between protons, between, let's say, gray matter and white matter, or water and fat. Though in reality, these substances are all very, very hydrogen rich and very biologically similar, okay? So in MRI, we're trying to determine the differences between these two items, let's say fat and water, but yet they're so similar that we need something to really express the difference between them, and I'm going to get into that in a second. The second thing is speed, right? So contrast acts to hasten the normal reactions in the body that allow us to do imaging. So contrast acts in two ways. But the idea is you want to make things magnetic, and so an MRI machine is great at temporarily magnetizing the body when you put it into an external field. Only 4 metals have this property. 4, only 4 on the entire table can become magnetized when put into a field. And those are gadolinium, iron, and nickel. 1, 2, 3. There's a 4th. Anyone know? Lithium. Well, not lithium. Iron, nickel, gadolinium. There is one more. I'll have to think about that. I can't think of the 4th one right now, but I forgot one off here. So there's very few metals that can be administered at room temperature that are liquid, that can also be excited by a magnet and then cause magnetism. So it's kind of it's an amazing thing to be able to confer a magnet to a living thing. Electrons have the same spin as protons. They're revolving in the same way, but since electrons are so much smaller, their gyromagnetic ratio, that's to say the ratio of how much magnetism to how much revolving, is much, much higher than protons. And the reason for that is because you're looking for cumulative spin, right? So because electrons are so small, they have the same spin, but you can pack a ton of them into a very small amount of space, and all of them are spinning. And depending on that spin, if you add a small amount of precession to that, they become magnetized. And if you have 657 to 1, you can imagine that's a lot of magnetism from a very small thing. So let's go into more detail about that, and let's first look here at gadolinium. So this is the structure of gadolinium. Gadolinium is lucky number 7 in its electron configuration. There are 7 unpaired electrons in its valence, which confer it to be extremely ferromagnetic. This is the gadolinium substance itself. It's chelated, obviously, so it's safe, and then there are these outer ring electrons that can then play with other things. So there's basically 2 major categories of contrast agents. Some are paramagnetic, those are the ones we use, and then others are supermagnetic, or they confer additional magnetism to an agent. So gadolinium is in that category of paramagnetism, and we have some other agents like that as well, and the unpaired electrons are what we are really looking for. Gadolinium has the highest magnetic moment, and it's the most stable ion of the ones that are listed, so that's why we use it, even though it's not as stable as we'd like it to be. The whole goal, the entire goal of contrast is to what? Make that T1 relaxation happen faster, right? And how do we do that? So I'm going to go into a little bit of MR physics here, so just stick with me. But basically, the idea there is to shorten T1 and T2. Shorten T1 and T2 relaxation times of neighboring water. It has a much, much, much lower effect on T1s and a higher effect on T2. So then we get signal out of that. And concentrations in clinical practice affect T1 weighted images much more than T2, or the T1 relaxation. And so at our clinical concentrations, we really are looking for the T1 effects of gadolinium and of substances in the body. So that can be really helpful at times, right? So like in the body, if you concentrate gadolinium, if you think about the places where gadolinium collects and then is concentrated, like the bladder, the kidneys do us a favor. They concentrate the gadolinium and they excrete it in much higher concentrations than we inject it. And if you look at that, what happens is at clinical concentrations, gadolinium is bright, right? So if this patient got gadolinium, and if you look at this, at the top, urine is going to be dark, right, on a T1 weighted image. Right in the middle, at this sweet spot, you will find that gadolinium excites the water or the urine and is bright. It confers a magnetic property and shortens the T1 relaxation to a point where you can actually measure signal. I'm going to get into more of this in a second. But just in your minds, keep up with me here, that the optimal concentration will result in bright signal. And then when there's too much gadolinium, similar to Suzanne just explaining to us about the lipohemarthrosis, at the bottom of the bladder where the most dense gadolinium sort of layers, you will find dark signal again, because at the highest concentrations, again, there's no more signal there. Does this kind of make sense to everyone? Because it's going to build on this in the next one. T2 is the opposite, but let's not worry about that for now. So looking at relaxation times, how does it work, right? So you put a patient in the MRI, they have protons throughout their entire body, and then you have this big magnet, like a tremendous magnet. Put the patient in the magnet, what happens? What happens to all those protons in the body? They're spinning like this, right? They're spinning like this. And what's that spin called? How do you describe that spin? Precession, exactly. So the way they spin is the precession. And in the body, they're not all spinning like this, are they? Some of them are spinning like this, others are spinning like this, some are spinning in the opposite direction. You can't measure anything like that, right? Because there's no cumulative signal in terms of the magnetism. What we want to measure is a magnetic property that represents most of the body, or a slab that we're exciting, right? So the first thing you have to do is you have to determine T1 relaxation. And so relaxation is basically when 63% of the excited protons return to their normal equilibrium state. So again, put a patient in a magnet, and all of the precession, hopefully a lot of it, will align with that of the magnet, right? It's like a dipole magnet. If you've ever played as a kid with those magnets, when you put them together, they stick, maybe they repel. And if you put a patient in the magnet, we have our own magnetism, just like that. So I go in the magnet, my body, all the protons start aligning with the magnet, right? And in doing so, then I can measure a difference. Because now, once I put the patient in the magnet, I can do other maneuvers, which I'm going to talk about, to then determine how those protons, after being put in the magnet, can relax and change and come back to their original state. T2 relaxation is the same, but for T2. And then altering, so you can use some different maneuvers here to determine the relaxation times of different substances. And the easiest way to do that is an RF pulse. So if you put the patient in the magnet, well, the problem with that is all the protons are then facing one direction. There's no signal there either, is it? The signal from that will be 100%, right? Because all of the protons are in the same direction. You can't tell the difference between water and fat because that magnet is so strong that there's no differential there. Does that make sense to everyone? Magnet is too strong. So what do you do then? How do you create a pulse? Like, how do you generate? Well, you've got to do something. And what we normally do is apply an RF pulse, which I'm going to get to in a sec. And then we get a T1 or a T2 weighted image based on that. So let's review and discuss here. Which of the following scenarios would the T2 shortening effects of gadolinium not be expected to be seen? So when would we not really see T2 shortening effects, which is kind of late? When would we not see these, these concentrated effects of gadolinium? Is it in MR of the bladder? Is it in arthrography? Is it venography? Or is it late enhancement of a cardiac MRI? This is a hard question. Yeah, please. Venography, excellent. Why do you say that?
Yeah, because on CT it depends on flow-related enhancement.
Wonderful. So what she's saying is that at these levels, when you're looking at the concentration, at normal concentrations we see T1 effects. At higher concentrations, this is where the T2 effects kind of occur when the concentration is too much. And so what we're seeing here, what I'm asking you basically, is where are these situations where the concentration of the gadolinium will pool? And yeah, if an MR of the bladder, it's a contained space. The more gadolinium you add, the more it becomes concentrated, and the kidneys are concentrating it as well. Same with arthrography. There's no fluid coming in and out. It's just the contrast agent itself. It's going to be at high concentrations. Venography as well. By that time, at that stage, you're going to have pooling of contrast in the veins and gadolinium as well. Not so much the cardiac MRI, right? Because that's going to be a delayed phase. It's going in and out of the interstitium, in and out of the muscle. So we should see physiologic concentrations of gadolinium there. So looking at magnetism again, we're looking for this at least one paired electron to confer some sort of magnetism. That means a magnet, just like the magnets that you used to play with when you were kids. And the goal there is to actually bend the magnetic field. So when you put the patient in the magnet, again, that 3T magnet is very strong, and your goal as a radiologist is to insert some inhomogeneity, to bend the magnetic field slightly. Why? Why do we want to do that? So we can see something, right? Because you got to look for something different. If everything in the magnet is the same, and it all confers to the major magnetic field, you won't be able to see anything. You can't capture a signal. All right, now comes the fun part. Who's ready to really learn? All right, let's start. I want you to put on your caps to MR Physics, remember back to when you learned this, and try to pull small threads of that knowledge into the talk today, because this is going to help our discussion of contrast agents. Put the patient in the magnet. This is the z-axis. Pretend the magnet is the z-axis, okay? And this big arrow is the patient's body. So you put the patient in the magnet, immediately all the protons align in this large z-axis. Forget what's going on here. So again, big, huge magnetic moment in the upper field here. Then we apply an RF pulse. Patient's in the table, all the protons are aligned in a certain direction, can't measure anything at that point. Apply an RF pulse and what happens? And an RF pulse is not magnetic, remember. What's an RF pulse? Radio frequency, RF, yeah. So it's not magnetic at all, it's nothing to do with magnets, but it bops all of the protons into another transverse magnetic, into a trans-axis right here. So it goes from this z-axis all the way down to the y, and you'll notice all of them do. All of them do. So all of these protons that are facing a certain direction, then they go into this field. They're still facing that same direction, and you can't measure anything in that plane either, can you? Because again, all of them started at the top. All of them were bumped into this y-axis. And there's no signal there either. So how do you measure signal in MRI? How do you measure signal? You wait. So as these protons the RF pulse turns off at some point, and then these protons start to come back. They start to come back into the z-axis. And as that happens, you can measure how long it takes for each individual substance to go back into the z-axis. And if you catch it at just the right time, when 63% of them have gone back to the original time, then all of a sudden you have some, let's see, right now 63%, you have some difference in signal because you've spread the magnetism depending on the thing. So water might be a little bit slower, fat might be a little bit faster because of its proton content, and then all of a sudden you can measure a signal in that, okay? So basically an MRI is an ordered collection of volumes of water. Protons are a magnet, you expose it to the RF energy, and then as it relaxes to the equilibrium state in the z-axis, thousands to millions of times more slowly than it did before, then you can create contrast and you can read that heterogeneity of the relaxation times to get contrast that you're looking at. Now, that's wonderful, but it takes forever. It takes so long. So the idea here is to add contrast. And if you add contrast, it acts as a very powerful microscopic local magnet. And what it does then is a magnet, it adds its own magnetism to the mix. So if you add another magnet into the setting, a more weak magnet than the big magnet, then you can speed this process up like crazy. And if you magnetize one electron with gadolinium, you have 6 more spots to bind other compounds. And then all of those are exponentially firing. And that water that you just excited can then transfer and excite another water. And that one can excite 2 more waters. And you can imagine that this thing happens very quickly, and then before you know it, you can shorten the T1 times that it takes to get back to the ZX and do tons of other maneuvers to get an image. That was MRI physics in 3 minutes or 4 minutes. So I know it's fast, but the goal here is, remember, magnetism and to confer some degree of difference in the tissue properties so you can measure it. You can measure it, and that's the goal. And a rapid chemical exchange, micro to nanoseconds, and it's catalytic with adjacent molecules. So let's look at this again. And I got to wait for the beginning now. So just everyone study this while it's happening, and then we'll look again. So we're going to start at the z-axis here. So all the protons are in the z-axis. You add the RF pulse into the cohesion or the transverse, and then you wait, and then you start to see they separate. And then as they're coming back, that's when you can measure the echo, when there's a slight difference between all of them. Does that make sense to everyone? Some of you might be asking, what's this 180-degree pulse? Does anyone know what that's for? Speak up.
It makes sense. When you apply 90-degree RF pulse, you make the spins to be out of phase.
Yep.
So that you don't have a signal. So when you interrogate with 180-degree RF pulse, you make them again in phase.
Exactly.
You get a signal.
Wonderful. So we have all the protons in the z-axis up here. Then I'm just waiting for this thing to align. We have all the we have all the protons on the z-axis here. We apply the RF pulse once. It goes into the x-axis. But that's not enough, is it? Even though they're separating here, you have to flip it into another phase to see the difference. And why is that? Because let's say that something was near iron. Let's say you have gamma antibodies in the spleen. Well, that's going to affect the magnetism of all the protons in the spleen, right? So you'll get an incorrect signal. So then you need to apply another pulse into the 180 degree, into the other direction, and that will rephase these protons again, such that you can truly measure the inert magnetism of every single proton not affected by magnetism that might be already inherent in the body. Then you image, and this is what? This is called the echo time. Echo time. Let's look at this in one other way. So this is that whole thing in 2D. Do you mind playing again? Sorry. And just you can keep hitting play until we're done here. I think you can just click on the button. No. Go back once more for me, would you? Will it play again? Oh, no. No? One and done? Let me try going back again. Hold on. Well, it's a GIF. Okay, forget this. We don't need this. Let's do it this way. And this doesn't need to play over and over again. Okay, so let's try this now. So this is another way of looking at it. MZ, this is the z-axis, right? And so we started a thing of 0. And then MXY is signal. So at 0, right, then this is the time it takes to return back to the z-axis. So we've got fat, we've got gray matter, and we've got water. Well, fat is full of protons. So it is going to return back to the z-axis the quickest. Gray matter is in between, and water is the slowest because it is a large molecule and it doesn't spin very fast to begin with. So you can imagine that at 63%, let's say like, here you can see differences between these signals. Whereas here, it's very difficult to measure a signal difference, and without any RF pulse, it's also very difficult to measure a signal difference. What else processes besides MRI and magnets? What other huge object that we identify and rely on? The Earth. Yeah, the Earth. So a lot of this work was replicated and understood because of the way our world also, and the Earth also rotates in the same precessional field around a giant magnet, which is the sun. So this is really cool stuff. If you open and broaden your mind and read about physics of our world and how the Earth revolves around the sun and how we have many magnets, it's astonishing how similar it is to MRI physics. Okay, any questions about MRI physics? That's the end of it. Any questions about that process or what I just discussed? Yes, please.
Sorry, I didn't understand you when you said that gadolinium tends to shorten T2 relaxation.
Okay, so gadolinium shortens T1 and T2 relaxation times. So it shortens both. And so its effect is dependent on its concentration. At human concentrations, the amount we inject, that's a whole, okay, so that's a good question. So this topic is on contrast agents, not on MRI physics. So I focused on T1, which is basically spin-spin interactions, like how an electron is paired over. T2 is more like NMR, so it has to do with the magnetic moment of the nucleus itself and the ways in which water and the proton then exchanges energy between its outer valence and its central core magnetism. But again, that's a whole other topic related to NMR and T2 shortening. T1 for contrast for human concentrations is where that's our bread and butter, which is why we don't really do T2 weighted imaging after contrast, because at our concentrations, the effect on T1 is so great. Other questions about the physics? That's important, right? So let's look at contrast agent design and rationale. So the whole idea here is to shorten those times such that we can image faster, right? So the idea of contrast is to design something that has a very high relaxivity, or R1, R2 quotient, such that if I put it next to something, it will make those electrons even more likely to interact with others and then shorten the time it takes to get back into the z-axis. It has to be stable. You can't have a free gadolinium metal ion hanging out in the body because they're extremely toxic. So you have to tightly bind it to a chelating agent. But no contrast agent is 100% resistant to dissociation. We would love some biodistribution. I would love that contrast agent to be picked up by the kidneys or maybe the liver, or maybe it's 100% extracellular. There are some contrast agents no longer, but the design of how it's picked up massively alters its half-life, like I talked about the other day, and it affects its ability to do its job. So we want to be thinking about that. We want it to be out of the body in a relatively quick amount of time, right? We don't want something that sticks around because then instead of a contrast agent, we've designed a medication, and that's not what we're looking for. And then finally, we want there to be a low osmolality. We don't want this thing to be pulling and pushing water in any direction because we don't want to have an effect on the body. Contrast definitely has high osmolality. Who has thrown a patient into volume overload because of a small amount of contrast? I have. And you thought it would be okay with a patient with CHF, let's say. That's not just because of the 100 cc's of contrast you injected. No way, because that's not that much. It's actually because of the tremendous osmolality of iodinated contrast and its ability to compete with albumin for the binding of water and pulling water out of the intravascular space. So we don't want that for gadolinium. And finally, when it extravasates, if you inject somebody and it happens to go into the soft tissues, it has to be safe. So let's look at the biodistribution of different contrast agents. They can be extracellular, they can be hepatobiliary, or they can involve the reticular endothelial cells. In terms of extracellular contrast agents, these are the ones that we're most used to dealing with. I use brand names, which I don't like to do, but I can't pronounce a lot of these easily. And so I'm hoping that the brand names are similar, but if they're not, raise your hand now, and that way I know not to keep referring it to the American name. It doesn't help any of you. But extracellular agents are what we're typically used to. Hepatobiliary agents are picked up by the kidneys, but also by the liver. And so in your head, be thinking to yourself that if an agent is excreted not only by the kidneys, but also metabolized by the liver, its half-life will be longer or shorter? Shorter, because it's being actively pulled out of the bloodstream by two organs, not one. So that's hepatobiliary, maybe a mixed agent like Eovist or Multihance. This was previously known, or some people call this Bapta. And these have very short half-lives comparatively, and therefore they're also safer. And then finally, there are contrast agents that live in the reticular endothelial cells only, and that's Feradex or furosemide. And those agents can be useful for looking at lymph nodes. And so these are the different type of contrast agents. We don't use hepatobiliary only scans. A Tesla scan says Europe here only, but I don't think you all use it here either, so it's kind of outdated. So let's look at some of these agents and get an idea of where we're at, right? Osmolality, we kind of talked about earlier, of the modern agents, Eovist, Dotaram. You can see these are all very low osmolality. Viscosity has to do with extravasation, if it goes into the skin, how thick it is, and if it's injectable or not. But let's look at stability here. So when you think about stability, it's logarithmic. Some of the least stable agents are known to be, as the stability number goes up, they become more stable, and as the stability number becomes lower, they are less stable. So some of the agents that were originally associated with NSF, like Optimark and Omniscan, have very low stability quotients. But of the newer agents, Magnavist, Eovist, even Gatavist, Prohance, they're very stable. And that number directly relates to its ability to cause NSF, which I'm going to talk about. What about relaxivity? So this is that R1, R2 quotient, the ability to cause relaxation. You want to be thinking about that in your choice of contrast agent. Eovist has a very high T1 relaxivity. The R1 is very high, so it's able to relax very efficiently compared to other agents, and therefore its dose is half that of Gatavist or traditional agents. So you want to be thinking about its ability to relax agents. It's not as good as Ablavar. Has anyone heard of Ablavar here? It's an intravascular agent. It's no longer available because it's useless, but it was thought to be a good vascular agent because its relaxivity was so high, and that's because it stays in the intravascular system the entire time. But as a result of that, you can't tell the difference between an artery from a vein, from a delay. Everything's bright all the time because it just stays there and relaxes everything, so it's not as helpful. Want to be thinking about half-life and how long it stays in the body. Again, be thinking to yourself, something like Eovist, compared to these other agents is going to be different. And then finally, the dose. Some of these have very low doses due to their biodistribution. I'm going to spend a little bit of time on this chart because I really like it, and it kind of talks about some of these different agents. If we look at, first of all, the structure, there are different structures of contrast agents, and it refers to the chelation of the gadolinium. And some of the comments here are helpful, like Magnavist was the oldest agent, originally approved in 1988. It does have an increased risk of NSF, but not as much as Optimark and Omniscan, and that's because they have low stability. So they have a much increased risk of NSF. We don't use these anymore. Dotarem is a really old agent. You probably all know it better than I do. In Europe, it's been used forever throughout Europe, as far as I know. It was recently introduced in the United States in 2016. That has to do with money and patents, because Dotarem is very cheap and it's generic in the United States, whereas newer contrast agents are not generic and they cost a ton of money. So Dotarem is excellent. We use a lot of this in our hospital. Dota is great. Gatavist is the other one. It has the highest viscosity, and it's the most popular contrast agent in the United States overall. Eovist is designed for liver imaging, 50% uptake by hepatocytes, 50% by renal. Very good at relaxing T1 because it intermittently binds with albumin on and off, and in doing so, it can quickly affect many other different molecules around it. And then Ablavar, we talked about just briefly, has a very long half-life. So looking at dosing of all these different agents, the best part about MR contrast is it's almost always the same. The dosing is very similar. You can give a standard dose if you want, based on their concentration, or you can do weight-based. At our institution, we give a solid 10 ml to everyone for almost everything. We used to give like 7, maybe 8, maybe 9, whatever. But if you actually look at the syringe and the way you inject it, you're never actually injecting exactly 7 or exactly 8 anyways. It's all within reason. So we do a standard dosing. I will definitely get calls from patients that are like, I thought the Eovist dose was supposed to be half. I was supposed to receive 6 ml. I got 10 ml. Why? But again, within these therapeutic ranges, it's absolutely okay to give a standardized dose as well. It does not have to be weight-based. In our country anyways. Okay, so dosing varies. 10 to 20 is fine. The injection rate is important, obviously. There's differences in pharmacy, safety, and cost. Okay, pregnancy use. This is the take-home point. Never, ever, ever, ever use gadolinium in a pregnant patient. Never, never, ever. And the reason is because there is an increased risk of stillbirth and neonatal death of a 3.7-fold increase. I've seen a lot of radiologists in my department kind of be casual about this, and they're like, well, it's perceived or blah, blah, blah. But for most pregnant patients, imaging can be delayed if it has to be an MRI until they're not pregnant, and if not, then do a non-contrast MRI. But spinal cord defects and teratogenesis is real. At usual doses, that said, in the patients that have received it, there isn't large-scale studies to prove, how many patients got this or that. But that said, there definitely is an increased risk of stillbirth and neonatal death, and they think it's likely due to teratogenesis of the spinal cord. Nursing mothers, this is a really important topic as well. A very small amount, less than 1%, is excreted into the breast milk and then absorbed by the gut. So I believe it's safe to continue breastfeeding with MRI. At a lot of centers, I know that the recommendation is to pump and dump for 48 hours and then resume breastfeeding. So I think it really changes.
I think in Europe, the recent guidelines don't need to stop breastfeeding.
Wonderful. Yeah, that's the modern recommendation. Same with us. But I know I've heard radiologists, even in my institution, kind of say, well, you can hold off if you want. And mothers, rightfully so, are worried about what they're putting in their baby's bodies. So I understand that. The MRI is rarely emergent, so women can pump and store unaffected, breast milk if they need to, and sometimes I'll give that information to them over the phone before. But if not, it's totally safe to do it, to do it afterward. So here's a case that I want to show you all. This is related to just kind of some of the stuff we've talked about. This was a patient that had cirrhosis, and my resident actually asked me and said, hey, I think the hepatic veins are occluded. What do you all think of that? And this is done with Eovist. So I think that the hepatic veins are occluded here. I'm purposely not showing you them on the Vibe and on the earlier phases. Why is it so dark? Who said that? I just heard it. What'd you say? Haha, so this is the same case that I just showed you, right? The venogram or the arthrogram or the bladder, where the concentration of the gadolinium is concentrated inside the vein, and that's what's happening here. So what we're having is, even though this is a T2 weighted sequence, after contrast, the T1 and the T2 concentrations at such a high concentration will null the signal. What do we call that? A flow void, but it's not really a flow void, right? Because flow voids are from T2 without contrast. This is actually the darkening effect after contrast. And we do our T2 weighted imaging after injection of EOS to save time, and I'll show you why. So let's do a little discussion here. Concerning the administration of gadolinium contrast to lactating women, which of the following statements is false? Which one's false? Not true. Peak injection excretion of breast milk occurs at about 50 minutes after injection. True or false? Maybe, we'll see, I don't know either. Let's go to B. Only a tiny fraction of the administered dose is excreted into breast milk. True. C. Only 1% of orally ingested gadolinium contrast is absorbed by the infant. True. Current scientific evidence shows that breastfeeding must be avoided for at least 24 hours. False. So that one's the false, so this must be true. And that is true. 50 minutes after is the peak excretion of the gadolinium into the breast milk. So the answer here for the false foil is that you have to stop. You have to stop. So looking at the safety of contrast, it's very safe. There have been a bunch of studies here. NOP in 2006 looked at 45 million administrations across a health database in the United States over 15 years and found the adverse reaction rate was 0.01, much, much, much less than that of CT contrast. A lot of people here ask me, like, what if a patient has a reaction to contrast on the CT side? Does that increase their risk of MR contrast reactions? Yes, it does, but only in the case of anaphylaxis. So if a patient has anaphylaxis to CT contrast, to shellfish, to peanuts, to whatever, their rate of atopy or atopic reactions increases generally as it does with gadolinium. But for mild reactions or CT, hives, itching, any of those sort of, erythema, any of those things, they're unrelated. But in terms of anaphylaxis, patients that are anaphylactic to one contrast agent or any item for that matter are definitely at higher reactive levels for everything across the board. At our institution, if a patient's had anaphylaxis ever in their lives, we premedicate. We premedicate. And I'll repeat that. If a patient's ever had anaphylaxis to something they ate or something we injected, we premedicate for contrast in the future because they're at such a higher risk for anaphylaxis again, and premedication is easy. Martin Prince at my institution looked at this in 2011 using a reporting system and found similar results. Desiree Morgan down in the south looked at 30,000 ProHens administrations and found no differences based on dose. So it's not similar to CT contrast where the doses are idiosyncratic but dose dependent. So NSF, we talk about this all the time. It's a little bit of a yesteryear topic now, but it's very close to my heart because this all happened when I was in residency. So it was first noted in 1997, and it's associated with gadolinium, was associated in 2006, and I was a third year resident then. Just a year before that, if a patient had severe renal dysfunction, like the worst, and they needed to get a PE study, we used to give a triple or quadruple dose of gadolinium, like 40 or 50 or 60 cc's of gadolinium, and then do a CT. I know that sounds crazy, but gadolinium is radiodense. And so if you inject a shit ton of gadolinium into a patient and then do a CT scan, you can see the pulmonary arteries. But little did we know at the time, because we thought that MR contrast was so safe, but no, repeated doses do lead to NSF. Luckily, we weren't using any of those agents that were described, but still, it wasn't great that we were doing that. And now looking back, I'm like, whoa, I can't believe we injected 50 ml of gadolinium into a patient who had known renal dysfunction. But that's what we were doing at the time. And exposure to gadolinium in patients with renal insufficiency or on dialysis, the NSF association is real. And it has to do with delayed excretion. So these patients have gadolinium that's just floating around, and naturally the chelation will start to dissociate as it binds on and off with all these different adjacent proteins. And in doing so, free gadolinium is very toxic, and it's inversely correlated with the stability, as we talked about earlier. So the idea there is to minimize use of gadolinium and also minimize the use of repeat examinations when you can. That said, the more stable agents really have a much, much lower risk of NSF. In fact, with Dotaram, and not Magnavist, but Multihance, there have been almost zero unconfounded causes of NSF. So it's very, 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 very safe. Omniscan and Optomark, not so much. Not so much. I would be very nervous about using any of these contrast agents today. And so again, it has to do with the form of chelation. Is it linear? Is it a ring? Is it ionic or non-ionic? A lot of agents. So in the United States, we classify these into 3 basic groups, 1, 2, and 3. 1 is a do not use. Like, we don't use these agents at all, period, no matter what. And those are the most dangerous. Group 2 is Multihance, Gadavis, Dotaram, and Prohance. These are few, if any, cases of NSF worldwide. We feel pretty safe about those. I'm not going to inject 50 ml and do a CT scan, but I feel pretty good in a patient with severe renal dysfunction, such that we don't screen for renal function at all with these agents. We don't at all. I used to, but now we don't. And it makes sense to me, regardless of renal function and also regardless of dialysis. So I used to be more stringent. This is like evolved, right? Back in the day, I might have told somebody, hey, when is their dialysis scheduled? Could we do the dialysis directly after the MRI? Should we wait until the contrast? Should we perhaps do dialysis, do contrast, and then dialysis again? All these kind of like cookbook, not really scientific methods of dealing with NSF and contrast. But the current thinking is for these agents, there is no need to do any screening, and you don't have to schedule dialysis in any way, shape, or form. Just continue living your life and giving these agents. Group 3 agents, EUVIS, there's very limited data, so you want to weigh the risk or benefits. At our institution, we don't check renal function for EUVIS either. What do you all do? I'm just curious. Do people check renal function routinely for these agents? Yeah.
Yes, we do for the last stage of renal failure.
Okay.
We calculate, estimate the glomerular
Gotcha.
fraction.
And using like 15 and 30 as cutoffs?
Yes, and sometimes we just skip in the last stage.
Okay, you'll skip it maybe.
Anyway, it's nephrotoxic a bit. It
Yeah.
doesn't increase the risk of nephrogenic system fibrosis, but it's nephrotoxic. It can decrease the renal function for some time.
Barely.
Okay.
Barely, yeah. So it's changing. Like I said, we used to check renal function. We used to check bilirubins for EUVIST, and then now we don't really do anything. And a lot of that is safety, just our experience. We haven't seen any of these cases. It's been like 15 years. But just in terms of our radiologist image, that damaged our image pretty badly, because NSF is so damaging. I'm sure you've all seen pictures of like the fibrotic skin and having depositions in your brain and in your heart. Patients viewed that as, and the lawsuits, everything, it was viewed as irresponsible on the part of radiologists, And our image is everything. Our image is everything. So if a patient ever asks you to talk about contrast, I don't have to tell you all this, you're all in front of the patient all the time, but I tell my residents, I'm like, get off your ass and go talk to the patient. Your image, your reputation, your perceived safety as a physician is everything. Even though you're a radiologist and you think, I'm, doing the sideline. No. To a patient, their perception is very important. So you want to be thinking about that constantly. So let's review and discuss. Which one of the following gadolinium-based contrast agents is less likely than the others to be associated with NSF? Dotaram, yeah, exactly. Dotaram, exactly. Good. So here's the first case. What do you guys think of this? There's a problem with an organ here. Which organ? Which organ is in trouble here? Liver, okay, I agree. So there's a big liver mass. And without contrast, this could be anything, right? This could be anything. Could be good, could be bad. If I saw this on a family member of mine, I'd be scared shitless. I'd be like, ooh, I wouldn't be, certain at all. But then you give contrast, right? And what happens? Like your heart rate goes down a little bit when you see this. And you say to yourself, all right, you're still going to probably require a hepatectomy, a right hepatectomy, because this thing is so big, but it's benign. This is a hemangioma, right? You can see the pooling of contrast around the periphery, and then slow filling, centripetal type filling or central filling on the more delayed imaging. So contrast solves the problem here. If it were just these images I would even say maybe it's just like a sarcoma met or something nasty, and this might go to biopsy, and then, biopsying hemangiomas is not a great experience. And so contrast saves the day. And in fact, some 80% of studies we do nowadays involve gadolinium. So it's essential, and it's really not something that we can, even today, so many years later, we don't have an alternative, do we? Like most studies that are pressing require contrast to help us to determine, what this might be. So let's look at the mechanism of action of contrast. We have either active or passive transport, and in the case of Eovist, DTPA, or BAPTA, these are ones that are excreted by the liver specifically, and the way that's done is by actively pulling it from the sinusoids. So we have this thing called an OATP transporter, and that is a specific protein that the gadolinium can bind to, and then it actively transports it into the liver. So this is not like the kidney where it's naturally being filtered at the GFR. No. For the liver, there's a protein there which is pulling it into the liver, which further decreases its half-life into the bloodstream, but also concentrates it in the hepatocyte, which is really great for us. So remember that name, OATP. And then there's another transporter called MRP2 that then will transport it back into the bile ducts. Okay, so does that make sense? So there's a first transporter to move the Eovist from the bloodstream into the liver, and then another one to then excrete it into the bile. And so that can help you kind of think about which pathogeneses of the liver have these transporters to transport the Eovist and then also excrete it. Does that make sense? So in the case of an FNH, why is an FNH bright? Why does it retain? It has normal hepatocytes, so it's able to actively transport with OATP, but does an hamartoma of the liver, which is, that's what that is, does a hamartoma of the liver, an FNH, when it's growing disorganized, do you all think it communicates with the bile system? No way. It's like the kidney. It comes up, and with it drags the ureter, its excretion, right? Liver is the same way. When it's developing from a plate, it has a hepatocyte-specific plate, which is, if you think about Crowley's disease, when you have these plate abnormalities and the dot in the center, that's all referring to the sinusoidal plate. An FNH is a hepatocyte. It can bring in the Eovist, but there's no communication with the bile duct beyond it. So it can concentrate the Eovist, making it bright, but unlike other tumors or liver, it can't then excrete it, so it stays bright. Does that make sense to everyone? Of why an FNH is bright? It also makes sense then why a well-differentiated HCC can be bright, right? But let's say another tumor like a colorectal met that's not meant to be in the liver at all. Well, there's no OAT transport at all, so it's dark. Easy. So, scanning techniques. This ability to use Eovist or BAPTA and inject is great, but the downside is it takes time, right? So Eovist, you can image the delayed hepatocyte at about 15 to 20 minutes. BAPTA takes longer. BAPTA takes up to 20 or 30 minutes. Idea there is you want to do pre-contrast imaging and then inject early, right? So because the T1 weighted effects will mostly predominate at clinical concentrations, we can give Eovist and then still do T2 weighted imaging while we're waiting for that delayed hepatocyte-specific imaging at the end. Does that make sense to everyone? Okay, cool. So FNH versus adenoma, we talked about this a little bit during the focal liver lesions talk, but I think it's worth reviewing again. And that is that for an FNH, it's a benign proliferative process. There's no follow-up reaction or treatment warranted. An adenoma is different, right? They hemorrhage, they rupture, they can malignantly transform. So first you want to stop the OCP and maybe even consider resection. Some adenomas will take up Eovist. Do you remember I showed in my case presentation how different it looks between the appearance of Eovist retention with an adenoma, which is sort of stippled, and the FNH, which is really bright. So you can kind of think of it. And they may have overlapping imaging features. So here's a good example. Anyone see a mass? So here's a mass. What's up with this center part? You remember? Scar. T2 bright or dark? T2 bright. And then on the delayed imaging, what's happening to the scar? Enhancing. So this is an FNH. Who would get an Eovist confirmation here? Yeah, me neither. So this is wonderful. If it looks like this, you're in great shape. But it doesn't always look like this. And so in that setting, you might need another agent. And this is an example of that. Does anyone see a mass here? Good one, huh? So again, this is a perceptual thing with your eye. Maybe you thought that was the intrahepatic IVC. I always kind of have to like do a double take, but this is not that. Are we done at 1 o'clock? Is that right? 1:15?
No, you were done 5 minutes ago.
Okay. That's okay. So we have a T2 hyperintense mass with arterial enhancement. On the delayed phase, not so sure. Like this one doesn't clinch it. So EOVIS for something like this could be really helpful to determine if this is an adenoma or an FNH. Here's another beautiful case. This is a case with the T2 hyperintense mass here. You can see it on diffusion, on an ADC, arterially really enhancing, and on VIBE kind of blends imperceptibly. Can't really tell for sure what this one is. The scar is maybe, but not great. But then when you do other sequences, and then especially the 20-minute VIBE, it really clinches it, and this is definitely an FNH. So it can be really helpful, and in the studies, I'll leave this to the slides, but it proves that adding EOVIS for the diagnosis of an FNH is essential. What about for metastatic disease? Also very, very helpful. Who here has found a metastatic lesion and then either on DWI or the EOVIS, the hepatobiliary, you're like, oh, where there's 1, there's 300. You know, you're like, oh my gosh, there's so much more than I expected. So I use EOVIS and DWI to look for additional lesions because I find that at the portovenous and the arterial, this is 1 met, but when you look on the hepatobiliary phase imaging, you often find multiple more. So it's really helpful for that as well. There are some limitations. You can get uptake in other types of tumors like fibrotic METs or well-differentiated HCC. We talked about the low signal vessels. Intense liver signal can obscure vessels as well if you're looking for, surgical planning, et cetera. The hemangioma we talked about in the last talk, and then this idea of a pseudocapsule is a problem, which I'm going to show you. There's special considerations if you have advanced cirrhosis or hyperbilies. But again, even at our institution now, we don't measure bilirubin before doing this imaging. And you want to find the ideal flip angle that will really optimize well for the biliary excretion. So here's an example of EOVIS retention in a classic HCC with arterial enhancement and washout. So don't use EOVIS just blindly. You kind of want to be thinking about when and how you're using it. Here's one with retention, and this was actually a fibrotic MET, and we found other ones as well. This was from breast cancer. This is a very tricky case of an FNH right against the portal vein, and another one on the side that I think we would have really had a hard time if we didn't have the EOVIS showing retention at the end. Another great example here, is this a mass, is this not a mass? And then at EOVIS you can see here, there's really nothing there and it retains completely, so this is also going to be another one. This is a fibrotic MET as well. You can see there's retention in that classic pattern that we might be expected to see. So there is a pitfall here, which is with the hemangioma, and then I'm going to stop here in 2 seconds. But at 20 minutes on the VIBE, remember, a hemangioma is not going to fill because it doesn't have hepatocytes. So be careful there. You're not looking for a complete filling, and similar to my last talk, you might catch the hepatobiliary phase too early, and in which case the excretion will make it look like it's dark when in fact it's filling. And this is the capsular kind of finding I was talking about earlier. When you have a big mass and you have a little bit of liver on the side, it's going to compress the liver and make it look like there might be retention, when in fact this is also a metastasis. So 3 questions and then we're done. Which agents had the highest association with NSF? Is it group 1, group 2, or group 3, or iron oxide? Group 1A, excellent. What percentage of IV gadolinium in doses administered for clinical MRI is excreted into breast milk? Is it less than 1, 10? Less than 1, excellent, A. And the final question, how do MRI contrast agents work? They shorten T1 relaxation, A is the correct answer. Lengthen T2 relaxation? No, shorten. Blocking radiation beams? That's CT, right? So she just rolled her eyes, I love that. Yeah, no, that's CT. And then reflecting sound waves?